Hi everyone, I'm Lauren Kriz. I am a pelvic floor physical therapist and owner of Cultivate Pelvic Health. I am here today with Alice Catalano. She is a certified nurse midwife. Today we are gathering and Alice has agreed to chat with me about women's sexual health, particularly as it relates to the birthing experience and how that can impact women's ability to be intimate afterwards. At the end of July is National Orgasm Awareness Day, and so we are doing a series of interviews to kind of celebrate that Awareness Day and truly bring awareness to how the tissues changes with the birthing experience. So let me tell you a little bit about Alice. Alice is a certified nurse midwife with over 4 years of clinical experience in Central Florida. She earned her Doctor of Nursing practice at Columbia University and currently works at the University of South Florida, attending births at Tampa General Hospital. Alice is passionate about providing trauma-informed and evidence-based care. Thanks, Alice. I appreciate you joining us.
Thank you so much for having me.
So as we kind of dive in, tell me and tell us what is a midwife?
In the United States, there are actually quite a few different kinds of midwives. I'll try to break that down for you. Um, I'm a certified nurse midwife, and what that means is anyone who has that degree has at least a master's degree in nursing, and is an expert in normal physiologic labor and birth, but can also provide sexual and reproductive health care throughout the lifespan. Birth control, annual exams, problem visits for gynecologic issues, postpartum care. In some states, there are also certified midwives, which pass the same exact exam as us, have the same scope of practice, but they don't have a degree in nursing. They have it in another field, but same midwifery training. Um, these two types of midwives primarily work in the hospital, but are able to work in the home and birth center as well. And then there are also certified professional midwives or CPMs. And CPMs work outside of the hospital setting, so the community setting, either homes or birth centers. And they do not have to have any graduate degree and learn through an apprenticeship process that typically takes a minimum of 2 years. And they provide uh, care primarily surrounding the birth, so prenatal care, labor, birth, and postpartum, and not typically gynecologic and reproductive health care.
Okay, very cool. All like great experiences, I'm sure, regardless of which path a patient might choose. But can you also tell me the difference between what a patient might experience with care with a nurse midwife versus a OBGYN?
Yeah, so it does vary a bit by practice setting. A nurse midwife who's working in like a private practice or a community setting may have the ability to do longer appointment times. Prenatal visits might be 30 minutes. I've even heard of hour-long appointments. The pace, it can be very different. And then you might be seeing a much smaller number of providers. Maybe 1 to 3 throughout the pregnancy, and then one of those people is the one who is with you for your labor and birth. Um, for midwives that work in academic medical centers or large hospitals with a high volume, you might not see as much of a difference between things like prenatal care or annual exams, just because the volume is higher. And so there's less time to spend with each individual patient, unfortunately. The scope of practice is different. So midwives are experts in physiologic birth, and really kind of step back when things are going the way that they should. They're also able to intervene when things do not progress normally, or if an induction is needed for medical reasons. So we can start labor, we can um, kind of augment labor when it is not progressing normally. Um, and those are all things OBGYNs do as well. But OBGYNs are really surgeons and they're experts in complications. So if a patient is becoming really sick or experiencing lots of labor complications, then it would be more appropriate for an OBGYN to care for them. And there are certain complications with birth that a midwife would not assist with. So if a baby needs to come out with assistance, like with a vacuum or forceps, or with a C-section, of course, then those are all instances where our collaborating physician would step in to do the actual birth and get the baby there safely.
Okay, fantastic. So in your setting, it really is truly a nice collaboration, right? So the midwife is
Yes.
able to start the birthing process in labor, but then if there's a complication that arises, then there's the OBGYNs on hand to step in and assist as needed.
Yes. So, the kind of hope is that none of our patients ever actually need the doctor. They
Right?
know that they're there. Our collaborating physicians are always aware of who the patients are. And, we have formal sign-outs and various parts of the day where we kind of discuss the course of every patient's care. But the hope is that we never, as midwives, actually need them.
Right.
Uh, but it is a very, very smooth kind of collaboration when we do need them to step in. And sometimes it might just be for help for a couple minutes, and other times they take over.
Okay, very good. So kind of on that note, and what brings us here to really kind of talk about the sexual health afterwards, as a pelvic PT, I see a lot of postpartum patients, and oftentimes they talk about how just they weren't prepared or they didn't understand what the birthing experience meant for their vulvar and vaginal health and how then that a lot oftentimes even at their 6 week mark where they're supposedly cleared to go back to having sex, they're not, their bodies aren't ready. It's perhaps they've had some stitches from tearing or an episiotomy, or just it was a really difficult labor, even like tailbone pain and so forth. Can you talk a little bit about some of, if you wanted to share widely with people complications, and they're not even like really complications, right? Like tearing is not super uncommon, especially if it's very small. And please tell me if I'm wrong. The bigger tear certainly would be a different story. But what women might experience both during the birth and then how that can impact their sexual health afterwards.
Yeah. So, um, one thing that people may not realize is pregnancy itself has an impact on pelvic health. So, even if you have a really, really smooth birth with no tearing, just carrying the weight of a baby for your pregnancy causes a lot of changes. The hormones cause a lot of changes. And so you can have pelvic instability and have function be kind of impaired both during pregnancy and after. Um, a lot of the data we have on sexual wellness postpartum is focused on heterosexual couples, so it has a little bit more to do with purely penetrative sex and less about like desire, lubrication. But in general, there are a few things that we can identify as risk factors for poor sexual function. Um, so first and second degree tears are very common and they are not always preventable. Third and fourth degree tears are are when the anal sphincter is involved. And those type of tears are definitely associated with complications. They can heal a lot more slowly. There can be anal incontinence or incontinence of stool, um, scar tissue, episiotomies, where instead of the tissue tearing naturally, the tissue is cut, can also lead to more pelvic pain. And potentially extension into a deeper tear, like a third or fourth degree. Um, Having a bigger baby, having your baby be in the occiput posterior, so like sunny side up position during labor or at the time of birth. And then any sort of operative vaginal delivery or assisted delivery, like with forceps or vacuum. And typically, that forceps are associated with worse pelvic injury. So there are things that people can do, but you can kind of do everything within your power during pregnancy, and ask for the right things while you're in labor and pushing, and still end up with an injury. And there can be a lot of guilt and feelings that patients didn't do enough, or that they should have done something differently. And no matter what, sexual dysfunction postpartum is not somebody's fault. And oftentimes, therapy can help with that in addition to more physical therapy.
Yeah.
Uh, so we know that perineal massage starting around 34 weeks, and that can be done by the patient or even by the patient's partner if desired,
Mhm.
can help to reduce those more severe tears like third and fourth degree lacerations, but not the more common first and second degree tears. Um, Warm compresses. So those could be applied by the nurse or midwife or OBGYN during the pushing stage can help, as well as the provider. Sorry, as well as the provider doing perineal massage can also help with those third and fourth degree lacerations. Um, Not everybody can tolerate those kind of things. So, if a patient is unmedicated, they're already kind of experiencing the kind of maximum of what they're able to handle. They might not want a provider touching them. Warm compress is almost always well tolerated and also can feel really good. But perineal massage might not be, and that's one of those things. If you couldn't tolerate it, you don't want your provider doing it, and you have a tear later on, don't feel guilty about it. That was the right decision in the moment.
Right. I think that's so important to talk about the guilt aspect. I mean, I, women in general, I think, and this is probably just a generalization, right? That we just carry guilt all the
Yeah.
time for so many
Yeah.
things throughout life. And then, especially with motherhood, it just doesn't stop, right?
Yeah.
And it is so, unfortunately, so common, again, for my patients as well, that maybe something didn't go as expected with labor and birth, and they just carry so much guilt. So I love that you've said multiple times, it it is, don't carry that guilt. You can do everything right and still a complication can occur.
Yeah.
So thank you for sharing that. Um, so I when we first started talking, I didn't realize that women could actually ask for things like the compresses or the perineal massage provided by the provider during their labor process. So I think that I just want to make that really highlight that we can be our own advocates and ask for those things. So that's very important.
Yeah,
Um,
so that's where, sometimes they're called birth plans or like birth wishes, birth preferences. That's where having a list can be really helpful. And it can be very hard to advocate for yourself, especially if you're um, unmedicated and just really focusing on every contraction and getting through it. So having a birth partner, whether that's a spouse or a doula, who can say like, oh, she really, or they really, really wanted warm compresses, especially in a busy setting, the provider really benefits from getting that reminder. And yeah, you should never feel afraid to ask.
Yeah, thank you. And then as far as like prep beforehand, you had mentioned the perineal massage starting at 34 weeks. Do you have any other recommendations that the mother could do to help prepare?
Yeah, so definitely meeting with a pelvic floor PT. Um, um, and some people, they may start experiencing dysfunction early on, pubic symphysis pain, just really bad pelvic pain. And so in those instances, um, we can refer for pelvic floor PT. But even if there is not a problem present, it can be very helpful for learning just like proper body mechanics. Um, it can be helpful for using the core, learning how to push with a relaxed pelvic floor, because there is an association with pushing against contracted muscle with worse pelvic injury.
Yeah, trying to push that baby out of a closed hole versus a nice, relaxed, open space
Yeah.
makes a difference, right?
Yeah.
Um, I also will provide my patients, especially if they're having pubic symphysis pain or SI joint pain or even tailbone pain, a positioning handout
Mhm.
that then they can bring to someone like you, correct? Where depending on what their birth plan looks like, epidural and so forth, that they can work with you on different birthing positions that can help prevent further injury of their pelvic area.
Yeah. Do you mind if we just pause for 1 second? I'm gonna try picking her up.
Yes, no
She's
problem.
very noisy.
Okay. Okay, we have a new little bundle of joy that's joined us.
Um,
So
yeah,
you're
it's
talking about the birthing positions.
yes. So if somebody doesn't have an epidural, then and if that's something you want prior to giving birth, it is a good idea to make sure that you're receiving care from a practice that's really supportive of different positions. Because ideally, if you don't have an epidural, we kind of just let you move in a way that is organic and feels good.
Okay.
Um, and then, of course, there are caveats to that if there are concerns with the baby's heart rate tracing, or certain aspects of labor progress, we might think a different position will be better. Um, but with an epidural, we really have to help position the patient. And so if there's an identified issue already where we know a certain position is going to exacerbate something, then that's wonderful to be able to have that information and have it, clearly listed for anybody who might be in the room helping with position changes.
Excellent. So just a couple more questions. So we've talked about the trauma that can occur, but what does that really mean, right? So I mean, I think everybody or most people have heard about tearing or an episiotomy or just that complications can occur, that their pelvic floor can be impacted. But I don't know, like, can you almost like draw a picture for somebody of what that looks like and what that can feel like afterwards?
So, um, it's a hard thing to answer because
I
every
know, I'm sorry, I
experience
threw this
is
one at
so
you.
different. Um, but vaginal tissue is very forgiving, and for the most part, it is um, meant to be able to kind of sustain these minor tears and then heal, and should usually heal fairly well, even if the tear is worse than normal. Um, the the issue is that sometimes that's not the case. And so a tear that goes into the muscle, of course, is going to be more impactful than one that is just affecting skin or tissue. Um, and sometimes these kind of tears can get infected, which significantly affects the ability for that tissue to heal. Um, some people might have a response to the suture material that's used. And so instead of it healing really well and easily, there could be excess inflammation. Um, Anyone who's had a prior birth with a complication of like poor wound healing um, really should be getting counseling around that because in some instances it might be preferable to have a C-section if there is a significant risk to the perineal tissues again. And if there's concern about more like lifelong impact to tissue. Um, we say that good nutrition can really be beneficial for tissue healing, good hydration, and then being able to not do very much in the first weeks postpartum, which for some people might not be realistic if they don't have a bedroom on the first floor. If they have toddlers that they have to lift and there really isn't somebody else who can kind of do those things for them, that can put a strain on those perineal injuries.
Okay, very good. And then finally, you had briefly mentioned that even if you don't have a vaginal birth, if you have a C-section, your pelvic floor can still experience dysfunction, even with healing and intercourse afterwards. Can you
Yes.
just speak just a little bit more on that?
Yeah, so vaginal birth is associated with an increased risk of prolapse and stress incontinence. But even after a C-section, there can be pelvic pain. Um, Typically, the kind of dysfunction that we see after C-section is a little bit more short term, whereas after a vaginal delivery, particularly a operative vaginal delivery, that can be more longer term dysfunction. Um, but during a C-section, the muscles of the core are separated. And so, um, you know, while with a vaginal birth, you might have a really sore perineum. After C-section, you really cannot use your abdominal muscles at all. And so other muscles might be overcompensating. Your pelvic muscles can become very tense. And then as the uterine scar, the scar on your skin, as all of these layers are healing, scar tissue forms and it forms adhesions, which are like little spider webs. And they cause tissue to stick and be less functional, just move in a way that's not free. And that can also cause a lot of tension and discomfort in the area.
Right. Fantastic. Well, I greatly appreciate you sharing your experiences and your time. Um, is there anything else that you would like to share with everyone as it relates to this topic?
Yeah. So, um, another really common thing that we see with postpartum patients, whether they had a C-section or a vaginal birth, is pain during penetrative intercourse. And oftentimes that's caused by low estrogen. Which happens postpartum, but is especially common with lactation. So, anybody who's pumping or breastfeeding. And it is not necessarily something that will just improve with time. Um, any sort of penetrative intercourse, ideally, there should be a lubricant on board, at least in the beginning, while patients are kind of figuring out if they're comfortable. Um, But a lot of people might need topical estrogen or vaginal estrogen, and they might just need it in the beginning for, maybe month or two, but they might also need it for their entire period of lactation, however long that is. Um, it just helps with tissue health, and can make things a lot more comfortable.
Fantastic. So, you know, I I encourage many of my postpartum patients to ask their provider for a topical estrogen cream. Um, can you should everybody just kind of, if they're planning on breastfeeding, just have it as a preventative measure, wait till dysfunction occurs? I don't think it's prescribed very regularly,
Mhm.
until somebody requests it. Do you have any recommendations for your patients on when to request it, when not to request it?
Well, it does take some time to work. So typically, the way that it is administered is every night for 2 weeks, and then 1 to 3 times a week as needed beyond that. So I think it's very reasonable to request it as a preventative and start it before a person is wanting to engage in sex. It can also the issue is it's not always covered by insurance, or if it's covered, it might not be great coverage. So it could be a more expensive medication. So, if somebody likes the idea of having it on hand and their coverage is good or the cost is reasonable to them, I think just requesting it and having it and using it if it's needed is great. Um, Otherwise, I would say just not to wait very long. So, if you notice an issue with the vaginal or vulvar tissue, there's irritation, any like stinging or burning, or even sometimes urinary type symptoms. If you like feel like you have a UTI, but you keep being told you don't, anything like that, vaginal estrogen is a great thing to try, and it's very, very low risk.
Okay, very good. That's perfect. Anything else that you thought of?
Um, and then I think lastly, 6 weeks is kind of an arbitrary period of time. When we see people for their postpartum visit at 6 weeks, that number is just when the size of the uterus has essentially returned back to pre-pregnancy size. But it doesn't really have any sort of implications on when a person will or should feel ready to return to pre-pregnancy activities, whether that's sexual activity or exercise. That can take significantly longer.
Mhm.
Some people might also feel ready really quickly, and in that case, I would try to urge them to wait.
Okay.
Um, but um, but yeah, there's really no scientific basis for saying that somebody should be ready to do things at 6 weeks. Um, So if it's taking a while, patients should not feel there's anything wrong with them. They might just need some more time, and they might need some assistance, helping those perineal muscles, helping the core muscles, and all of that can be really great to do with a pelvic floor PT.
Fantastic. Yes. And I would love to see everybody who could use some of that assistance for sure. All right. Thank you so much. I really appreciate you taking the time. And if anybody wants to come and see you as a provider, how would they find you?
I am at University of South Florida. You can just ask to see Alice.
Okay, perfect. All right. Thank you, Alice.
You're welcome. Did you